Okay, welcome everyone. Thanks for joining us today. So I will start with introductions, and they are they are impressive, and I will go through a fair number of them because I want you to because that much hard work deserves recognition, but also because I want you to understand our speakers' backgrounds so that you can best frame your questions to them as we go along. So presently, Dr. Connor Kerns is the director of the Anxiety, Stress, and Autism Program Lab at UBC. She received her master's and doctoral degrees in clinical psychology from Temple University in Philadelphia and completed her pre-doctoral internship in pediatric psychology at AI DuPont Hospital for Children in Wilmington, Delaware. She is trained extensively in the assessment and cognitive behavioral treatment of child anxiety and related childhood disorders at the Child and Adolescent Anxiety Disorders Clinic of Temple University and the Child OCD Tics, Trick, and Anxiety Group, University of Pennsylvania. She has also had the privilege to train and collaborate with the Seaver Autism Center at the Mount Sinai School of Medicine and the Center for Autism Research at Children's Hospital of Philadelphia. Following are a few of Dr. Connor Kerns' areas of interest and research: anxiety and ASD. Dr. Kerns' present research focuses on the overlap, assessment, and treatment of anxiety and autism spectrum disorders, more specifically to explore the varied presentation and phenomenology of anxiety and ASD and the implications of this variation for effective anxiety measurement and treatment. Another interest is the impact of trauma. She plans to extend this work to the understudied area of traumatic events in youth with ASD. Technology. She is also interested in the use of technology to facilitate this dissemination of empirically based treatments. Her long-term goals include developing a parsimonious model of psychiatric co-occurrence to inform the design and dissemination of cross-diagnostic assessments and treatments that will improve child well-being and development. Okay, so today, Dr. Kerns and her team members will present two studies which investigated the sources and symptoms of trauma in autistic youth, one of which involved input from the autistic adults reflecting on their own childhoods. And then they will talk about studies for which her team is currently recruiting participants. These are focused on understanding social emotional processing, adversity, and well-being in young adults on the spectrum. Working with Dr. Kerns in the ASAP lab are grad students Michelle Hunch, Elise N. Cordell, Charlotte Stewartson, Erica Thauberger, and Kate Rowe. Elise and Kate are also with us today. Elise N. Cordell is a PhD student in the clinical psychology program at UBC, and Kate is the ASAP lab manager and research coordinator. She has a BA in psychology from UBC and is particularly interested in the long-term mental health consequences of childhood adversity. So with that, I will allow Dr. Kern and her teammates to share the screen and to take over. So welcome to you.
Thank you so much, Joette, for such a lovely introduction of us all. All right. So, can you all see my screen?
We can. I can.
Amazing. Everybody else? Okay, great. Let's see if I can play this. So I thought today I have a number of slides to kind of go through, and I'm going to focus on some of the studies that we've conducted to really better understand what might be the sources and distinct expressions of trauma, psychological trauma, including but not limited to post-traumatic stress disorder in youth on the spectrum. and talk about some of our emerging studies too, our new studies that are going on now for adults. But I wanted to say that I'm very happy for this to be a conversation. And if Kate and Elise can keep an eye on the chat or the bottom screen for me, if you'd like to ask me questions as we go through, I'm completely comfortable with that. And I'll just kind of watch the time as we go through. Or we can save questions to the end. It's really up to you. But I'm really happy to have a conversation about these issues. And I hope that the slides are just a starting off point for kind of conversation. All right, let's see. We've had a beautiful land acknowledgement from Joette. I also want to just acknowledge that the land on which I'm presenting from today is the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people here at UBC, and I feel very fortunate to be able to teach, work, and play on these lands. I also want to acknowledge that a lot of the work I'll be presenting today has been supported by federal grants from the Canadian government, but also the US government, which is because I did a lot of my original training in the US. This is our team. It's a little bit of an outdated picture, but here's some of the members of the Anxiety, Stress, and Autism Program at UBC. And as Joette mentioned, our mission is really to improve understanding, assessment, and treatment of anxiety and stress-related conditions in autistic individuals, particularly youth and young adults. And I do want to acknowledge, I realize I'm speaking to the Square Peg Society, that there's a focus on adulthood here. Like many clinicians trained 20 years ago, and I'm dating myself. I was primarily trained as a child psychologist. So that was my kind of training background. And you can hear that even in my history, kind of the places I've worked, a lot of pediatric hospitals, et cetera. And for the time, that was really kind of the state of autism research and clinical practice 20 years ago. And it was a big problem. And I think that it's being increasingly recognized that autistic adults need support, research dedicated to them as well, and that there are changes happening, but it is definitely a slow progress. And you can see that in kind of the dearth of services available to support autistic individuals in community settings, but also just that the research is really playing catch up at this point in focusing on the needs and the experiences of autistic individuals. I think if you look at my training background, that is an illustration of that. That being said, even though my training is in children, because of the huge need for autistic individuals, particularly around mental health concerns, my lab and my work is increasingly moving towards the adult domain. Particularly, some of my graduate students are very focused on understanding diagnosis of autism in adulthood. And many of our studies right now are focused on the mental health of individuals as they transition from childhood into young adulthood. So you can see the work that's kind of happening there. But just wanted to be full disclosure on kind of what's been going on the last 20 years in autism research and how much is changing now. And I also want to note that for the presentation, I will predominantly be using identity first language, just because we do have a lot of research coming out right now that tends to be the priority or the preference for the majority of autistic individuals who are able to indicate a preference. Not everyone. And I will say that if you work with us in the lab, we really like to try and use the language that you feel most comfortable for. Everybody has different preferences, but in the presentation, I will predominantly use identity first language to kind of understand the majority preference, although sometimes I go back and forth knowing that people have different opinions and feelings about it.
What do you mean by identity first? Like,
I mean, yes.
Mi amor, mucha suerte, ¿ok? I do the manos. De manos. Un besito más, un besito.
Thank you for that question. Identity first would be...
Y perdón por el peo.
What's going on?
Could I ask that?
Ya, aquí estoy en eso.
Identity first would mean autistic individual as opposed to an individual with autism or individual with autism spectrum disorder. And I think this is because as we learn more about the autistic population, there are varied views about how people feel about their autism, how much they identify it, whether they feel it is an important characteristic and not, and how they want to identify themselves, and others who see it as more a part of their identity or maybe not a central focus of it, and so don't want to identify as autistic individual and prefer the term person with autism. And we really see a variability in our lab and all the folks that we work with. So we try and respect that variance of opinion.
I'm going to ask that everybody who is not asking a question, please mute their microphone. I'm looking for
Like Lena.
You might be able to manually mute
trying to see.
too.
Lo siguen dando en horario que es y en Tunja, 6 de la tarde. A las 8:15, Deportivo Pereira, remodelado, recibe al
So while we're
Deportivo
waiting
Cali.
for that, I'm
Sí,
curious, there was a whole big thing that I was exposed to. People don't want to be identified by their thing because they're first and foremost a human being, and they're just a person with whatever the thing is, a person, whatever it happens to be, in this case, autism. Now it's gone back to the other way.
Yeah. So, for example, when I started my training 25 years ago, it was considered more respectful, and maybe the majority opinion to say a person with autism spectrum disorder. So not to identify, but the feelings about that have really reversed. And I think, people have a lot of different opinions and perspectives on this, but the perspective that I've heard expressed is that when you position a person with autism spectrum disorder or autism, that has an inherent suggestion that autism is a problem or a negative thing that the person is dealing with. And for some people, it's actually a really critical, important part of their identity and something they view as a strength. So they prefer to say, I am an autistic individual, this is who I am, it's central to it, and it's nothing to feel negatively about. Other people have different feelings about it and kind of their relationship to what autism means to them and their life, how central it is, but also kind of their relationship with the term autism. So there's hugely varied opinions about this and experiences, and our position at the ASAP Lab is that we really just want to respect where each individual is coming from and their preferences when working with them. Okay. All right, so I just wanted to say, and Joette kind of gave a nice overview here, but I would say that our work in the lab kind of falls broadly into two categories, particularly the work that I'm leading, which is to look at anxiety and the way that anxiety impacts individuals on the spectrum, understanding those experiences, figuring out how we better assess anxiety disorders and can more effectively treat them for folks on the spectrum. And again, given that my focus is children, often in youth. But the other big part of it is understanding adversity and also what might be considered a traumatic reaction and a source of traumatic stress. And the reason I got interested in this work is actually from the work I had done in anxiety, where we are seeing a lot of co-occurring mental health conditions in people on the spectrum, anxiety, depression, ADHD, just a lot of co-occurring mental health. And we know that one strong risk factor for mental health conditions is early childhood adversity. And yet for some reason, that was not being talked about much at the time in relation to all these mental health conditions that were being studied for folks on the spectrum. So it seemed like a really important perspective that was being under-evaluated. I also noticed in doing that work that the rates of post-traumatic stress disorder, particularly in children at the time, were not actually being reported in many studies. And sometimes they weren't necessarily reported as being at a higher rate than we would see in the general population, which was interesting to me and somewhat curious, just given that it was not clear to me why folks, particularly children on the spectrum, would be protected against PTSD or not at risk. Particularly given my knowledge of just a lot of adversities that people on the spectrum can experience and the high rate of all these other mental health conditions. So it was a big question mark for something and just something for me and something I wanted to explore further. So I'm going to take you into some of that work and, that curiosity that I had, that question mark. As I mentioned, until recently, the role childhood adversities play in kind of the prevalence of mental health conditions and observed in autistic people has really been understudied. This is curious because we know childhood adversity is a major risk factor for mental and physical health in the general population. And it's particularly curious given we know so many other mental health conditions occur at a higher rate in folks on the spectrum, but somehow not PTSD. That becomes even more curious when you actually see that there are some studies now looking at post-traumatic stress symptoms in adults on the spectrum that would suggest some potential increased risk for post-traumatic stress symptoms in adults with autism. So it again becomes more curious, why are we not seeing that in children? And also we know that autism can be associated with a number of risk factors for post-traumatic stress. Number one, potentially being exposed to an increased rate of adversity, but also things like having pre-existing anxiety, intellectual disability, and social disconnection are all kind of known risk factors for post-traumatic stress in the general population. And so it's curious to know that many of those things are also associated with autism. Why would we not be seeing an increased rate of post-traumatic stress disorder in youth on the spectrum necessarily in the studies? So there are just a lot of things that didn't really seem to line up here for me, and thus warranted research investigations. Another thing that we kind of found as I started to do this work is that if you actually survey community providers who are working with autistic youth, and this was done in the United States, we surveyed a large number of community autism providers from multiple disciplines. So folks who were working in mental health, but also allied health positions like occupational therapy, speech therapy, physical therapy, behavior analysts, special education. And we just asked them, in your usual care, when you're working with youth on the spectrum, are you inquiring about potentially traumatic events? Are you screening for them? Are you treating trauma-related symptoms? And what we saw is that actually the majority were asking about these things. Over 50% were saying they were screening for potentially traumatic events. And over 50% actually said they were treating trauma-related symptoms in their clients on the spectrum. This is really fascinating to me at the time because it really illustrated this disconnect between where the research was and the topics that researchers were focusing on, which were not trauma, PTSD, or treatments for traumatic stress, relative to what was actually happening in the community, which is if you ask these community providers, they were saying, no, we're seeing this regularly, we're asking about it, and we're kind of doing the best that we can, given that this is a current issue that is coming up. What was also really interesting from this study is that the community providers felt over 75% agreed that it was very important to identify trauma symptoms. It was a needed service for autistic youth. And also that at the same time, they felt that they lacked the training to accurately identify those symptoms. They lacked the training to treat them. And over 50% agreed that there may not be effective treatments for traumatic stress for folks on the spectrum. So these numbers just kind of illustrated to me on a large community level some concerns I had as a clinical researcher, that this is a very important topic that people are having to deal with in the community that the research community was not really keyed into yet. We also just did start to do some research to try and better quantify this feeling I had at the time, or notion that probably children on the spectrum might be experiencing more childhood adversity. And we tried to get some numbers on that. So this is a population-based study in the United States. It's a large survey that goes out to a representative subsample of the US population. And that includes a subset of children who are on the spectrum. And what we learned from this research is that children, autistic children, were significantly more likely to experience multiple adverse childhood experiences. So these are the types of events that tend to be related to increased mental health and physical health conditions in a lot of population-based research. We're seeing more of them for kids on the spectrum. In the US, we also particularly saw that children who were living at or around the poverty level were particularly at risk. So we know that children living at or around the poverty level in general often experience more childhood adversity. It seems to be particularly the case for children who also had an autism spectrum disorder diagnosis in this survey. So this was just some good population-based numbers, again, kind of supporting these questions or these ideas, hypotheses we had as researchers that folks on the spectrum might really be at risk. And what's important about this study is that it's population-based. And I just want you to like keep in mind that when we talk about prevalence rates or who's at risk or not, it's very important to have these samples that really represent the broader population, as opposed to just treatment-seeking individuals or individuals who agree to participate in a study that they know is about trauma, because often those individuals, they may or may not be representative of the broader population, right? Often if someone is seeking treatment, the likelihood that they are experiencing some kind of challenge that is bringing them to treatment is much higher. So they may not be representative of the full autistic population. Okay, so that's why even in this broad population-based sample, we are seeing increased rates of adversity. Now this also brings us to the question of how do we define adversity? When are adversities actually considered traumas? And this is a really complicated question. It is very messy in the literature. People use the term trauma to mean a whole bunch of different things, including researchers and scientists. But I think one way to try and wrap your head around this is to just think about that there are at least two kind of broad categories or ways that we could think about defining trauma. One is a very narrow definition, and some folks call this trauma with a capital T. And what that means is trauma as it is defined but clinically in clinical manuals like the DSM. This is what kind of doctors use to make diagnoses of post-traumatic stress disorder. In that manual, there are specific events and types of events that are listed that are considered potentially qualifying for a diagnosis of PTSD. And in order to move forward with even giving a diagnosis of PTSD, you need to have experienced an event that falls into one of these categories. And this narrowly defined sense of big T trauma or criterion A events, they're called for PTSD, include kind of exposure to death, threatened death, actual or threatened serious injury, or sexual violence. And this can come through direct or kind of indirect exposure. So witnessing somebody else, for example, being abused, could also qualify you for potentially getting a diagnosis of PTSD. So that's a very narrow but specific way of defining what a trauma could be and necessary to move forward with a diagnosis of PTSD using a manual like the DSM. But it's also important to note that many people also think about trauma in a much broader way and use this kind of broader definition of trauma can be any kind of event, series of events, or set of circumstances that are experienced as physically or emotionally harmful and life-threatening, and which have lasting adverse effects on individual functioning and their well-being. So when you think about trauma in this way, kind of little t trauma is often how it's referred. It's any kind of psychological injury. So anything that happens that has a really negative long-term impact on the individual, whether or not it kind of fits into these specific categories or definitions of the DSM, okay? What is true for both of these definitions, and really important to keep in mind, is that trauma, as opposed to a potentially traumatic event, really refers to not only an experience, but also the way that experience is appraised and the way that it affects the individual, right? So a car accident itself may or may not be a trauma. I would actually classify that as a potentially traumatic event. The car accident becomes a trauma when it results in kind of lasting mental health or physical health problems for the individual, right? So, and it is appraised by the individual. The individual thinks of it as something that was traumatic, something that was more for them they could kind of handle in terms of their coping resources at the time, okay? So when we talk about trauma, it's not just what happened, it's about how the person experienced it. Those two things have to go together.
I had two questions.
Yep. Mm-hmm.
One is, so you're saying the broader definition is not recognized in the DSM. They're still like you have to have been a soldier at war to be PTSD.
It's better. It's not just soldier at war anymore, but that's a really great example that you brought up, because that is exactly where PTSD started, right? And in early versions of the DSM 30 years ago, that's basically what it was. And then they grew from trauma related to war to, well, actually, maybe you can have a similar kind of reaction if you experience abuse, right? Or an assault. or a car accident, or maybe if you witness it. So even what's in the DSM has actually grown over time. And in order to move forward with PTSD, you still need to fit into that DSM category. But there are some other manuals out there like ICD-10, which is a diagnostic manual that clinicians use that's developed by the World Health Organization. And it is more flexible and allows you to actually use a broader range of events to potentially qualify for post-traumatic stress. But I think the other thing I just want to note here, and this might actually go to my next slide, is that another important way to think about trauma is that some traumas may result in PTSD and post-traumatic stress symptoms. That is actually a small group of individuals who are exposed to adversity will develop PTSD, maybe the full criteria, they get a diagnosis. A broader group will develop post-traumatic stress symptoms, but maybe not meet full criteria. But many other people, in fact, PTSD is the minority response to these types of events. Many other people will just develop anxiety disorders, depression, other kinds of mental health struggles, and sometimes physical health difficulties. So another way of thinking about the little t trauma is just recognizing that when we talk about trauma, we're not only talking about PTSD. PTSD is one slice or one little mini circle in this broad circle. A lot of other people, their expression of trauma might really be through just broader mental health conditions. And for example, if you look at the case of children after for example, the World Trade Center disaster in New York. So New York City is where I grew up. The most common diagnosis for children in New York City after that disaster was actually separation anxiety disorder, and as opposed to PTSD. Okay. But it would be an important way to think about it is, do we just think about those children as having separation anxiety disorder, or do we understand that there is some kind of trauma going on here, that part of what's going on is a reaction to what they've been exposed to?
Now, the second question I had is the trauma. You said it's the appraisal of the trauma. Does that include, because what I understood was how trauma manifests later in an individual is how they were treated after the trauma. So if they had gotten support, if they were trivialized, so that the effect of trauma isn't the trauma itself, but how they're treated afterwards.
That's a really interesting way of kind of putting it. So when I mean appraisal, I mean that when you talk to the individual, when they reflect back on what happened, they feel that it was a traumatic event, right? So they feel that it really had a negative lasting impact on them, that it was something that turned their world upside down, that they have not been able to get past, etc. So, and a big part of that is the ability to access social support afterwards. So that's another one of those big kind of risk factors or mechanisms that can be in play, is the ability to connect socially. And at least for, this is in the general population. Again, we have less research for folks on the spectrum, okay? But the ability to be heard, understood, believed, supported, right? Connect with individuals can often lead to a better outcome after a potentially traumatic event than folks who are not believed, don't get social support, right? Feel increasingly isolated. That is more likely to lead to post-traumatic stress disorder, but also kind of these broader types of potentially traumatic reactions, which for some people are more anxiety and depression and other mental health problems, substance use. And I just have at the bottom of this slide, the minority of those who experience even criterion A, so the big T traumas, the things that the DSM would say, yes, that could be a potentially traumatic event. The majority of those people, the minority of those people actually develop PTSD. And we also see from research, again, not in autistic populations, that even what are called low magnitude stressors, so things that don't meet the DSM's definition, so things like breakups, that they can actually also result in traumatic stress symptoms, even if not a full PTSD diagnosis. So it just goes to show you we have to be really open-minded and flexible in the way that we think about these things. Yeah, I see another question from Miriam.
Yes. Will you be mentioning complex PTSD in your talk today?
Not too much. I can try and field some questions about that, and it's something that we did take into account in one of the studies in thinking about what types of symptoms to ask about, but it's not a specific focus of the talk.
Okay. Are you familiar with the research that's been done at the famous Israeli autism research? I forgot what it's called, but I've read a few articles from
Put your
there.
hand up, Roland.
I'm sorry.
Like Haruvi Lamdin and Ofer Golan and those folks.
I can't remember. I have a bad memory. I can't remember, but it's the place in Israel that does that. There's a very famous one, and I don't remember that. I read these articles a little while ago, but they were about how for autistic individuals, whether or not they were diagnosed at the time, many of them get diagnosed much later in life, but that ongoing childhood trauma of the small letter kind, not the DSM-5, but the World Health. The World Health also recognizes complex PTSD, whereas the DSM-5 doesn't. But that this can result, that these types of traumas are especially likely in autistic individuals to result in lifelong, full-blown trauma symptoms. When they later take tests, they show all the symptoms of full-blown PTSD, whereas that might not be as likely in non-autistic individuals. That they experience things as life-threatening, possibly, that other people don't.
Yes. So I think we're rowing in the same direction. So part of the reason I'm spending all this time talking about little t trauma versus big T and kind of these distinctions is because we think it's really important when we embark on trying to understand what are potentially traumatic events and reactions for folks on the spectrum to take a much broader view, right? For exactly the reasons that you've articulated. What I want to make the point on this slide is that I think that may be particularly true for autistic individuals, but it's not only true for autistic individuals. So even in the broader population, there is just prior research from 2010. So not even like the most recent stuff. This is something we've known for a while, that you don't need to have a criterion A event or a big T trauma to demonstrate some traumatic stress symptoms. Other types of stressors can really result in that. And there is this emerging knowledge of kind of complex PTSD, which is thinking about kind of really chronic, cumulative negative experiences and how they actually influence the person, and thinking about a much broader kind of expression of PTSD than what's written into just the DSM, right? And so those were all things that we were thinking about when we're trying to think about, well, how do we actually measure and assess what could be a potentially traumatic event for somebody on the spectrum and their reactions. So basically the theory we had kind of going in, and I started this work probably about 10 years ago, was to think about the possibility that if you're on the spectrum, that might interact with and influence the types of adversities that you're exposed to, right? So increasing the rate of those adversities, but also the quality. What are those experiences that you're exposed to that could potentially have a traumatic event? Are they being asked about on our standard questionnaires that weren't developed for people on the spectrum? How likely is it that that experience is going to be appraised as a traumatic event? So this is really thinking about that point of, for somebody on the spectrum, they might really experience something as traumatic that maybe somebody who is allistic or not on the spectrum would not view in that way, and that is not recognized in the DSM or even in just broader literature, right? We're just not recognizing that maybe that could be a trauma for somebody on the spectrum, warranting a more tailored approach. And then finally, that the way that a traumatic reaction expresses, how similar is that, but also are there also distinct expressions of traumatic reaction for people on the spectrum that are potentially being missed? And for example, is that why we're not seeing really consistent pattern in the literature of children with autism having increased rates of PTSD. I mean, some studies suggest they're not even reporting it at all. Is that actually because they're not experiencing traumatic stress symptoms, or is it because we don't know quite how to look for it or assess it accurately in that population? The criteria that we have were not developed for autistic children, so maybe they don't fit or suit them very well, and we're just missing it. Okay, so these were kind of the questions going in. So I think we're thinking in the same way, the way I'm hearing your questions. And if you're talking about Haruvi Lamdin and Ofer Golan in Israel, who are folks that I collaborate with, yes, we are talking to each other and thinking very much along the same lines, that in order to truly understand how adversity plays a role in the mental health of autistic people and to better understand who's actually having a traumatic stress reaction or PTSD, we need to broaden our lens about thinking about what a trauma might be.
Can I add one other thing too, is that I think what I hear from the autistic adults and from their families is that it is particularly the cumulative repeated incidents over a long period of time and not followed by appropriate supports. So while their families might remember a meltdown event, what they experience is a long series of put downs, misunderstandings, being ignored, their concerns being ignored. And over time, many have described that as trauma to me.
Mm-hmm. Yes, so that's also a finding that we're seeing in the literature. So with that, I'm actually going to jump into the first study. So coming at this saying, okay, we think we need to start fresh, right? Before we start studying adversity, potentially traumatic events, traumatic reactions in folks on the spectrum, we need to do better than just taking all the measures and honestly the neurotypical conceptualizations we have about what a trauma is. And we need to really talk to autistic individuals and the people who support them about what they think might be the sources and potentially signs or indicators of a traumatic reaction in autistic individuals. And again, at this time, I was particularly focused on youth, but I think there's a lot of relevance to this to adults as well. So we wanted to set out to think about this in a more tailored, autism specific and informed kind of way in beginning the research program. So we started out with a qualitative study, investigating and interviewing 14 autistic adults and also 15 caregivers of autistic individuals of varied ages, asking them what they thought, looking back on their lives or their child's lives, were the sources of trauma for themselves or for their children. We used semi-structured interviews with all the participants, and we gave them this broader definition of what a trauma could be, the one that I went over with the small t on the prior slide. And we said, okay, thinking about this definition, are there any events or experiences in your or your child's childhood that may have been traumatic? Tell us what you think. And then we transcribed all those interviews and we coded them using a thematic analysis in two different ways. One was called a kind of a deductive approach, and that means we had some ideas going in about what we were kind of looking for. So we went through the interviews and we tried to code things that we thought we recognized as kind of traditional forms of trauma. So things like maltreatment, life-threatening accidents, abuse, neglect, things like that. But we also used an inductive approach, which means reading through the interviews, we identified kind of themes that were emerging across the interviews about potentially novel or not previously recognized or fully considered sources of trauma for autistic individuals. And just to talk a little bit more about the sample, as I mentioned, we had 14 autistic adults who did these interviews with us. I actually interviewed absolutely everybody in this study, which was a really amazing experience for me. The autistic adults ranged in age from 22 to 64 years. We had 9 who identified as male, 4 female, and 1 transgender individual. Predominantly Caucasian, although some variability in racial background. The majority were making less than $25,000 a year in US dollars in the US, so did not have a lot of financial support. and 3 had a prior diagnosis of PTSD, but you can see the majority did not, even though they kind of identified as having experienced a trauma of some kind in order to be part of the study. For caregivers, we had 15 caregivers, predominantly moms. Again, majority were Caucasian, but we had some variability in terms of racial and ethnic background here as well, a mixed income and educational level. And importantly, we wanted to use caregivers to kind of represent a broader range of individuals on the spectrum that then we could actually interview themselves. So caregivers represented individuals who ranged in age all the way from 5 to 29 years old. So we had parents of children and parents of adult children. The parents also, their children ranged in terms of their communication abilities. So we really ensured that the caregiver sample, we were talking to parents of individuals who included some individuals who had very little verbal ability, so could not communicate verbally and had a more significant kind of functional support needs. And 2 of the kids had a prior PTSD diagnosis, but again, not the majority, even though their parents were identifying potential trauma. Okay. I'm going to move this. We did give everybody in the study a kind of standard questionnaire. So this is something you might see in a lot of other studies of people without autism, just asking about potential sources of trauma to kind of understand what of those traditional things that are often asked about, what do we see in this sample? And what you can see overall, and these are not, this can't give us a sense about prevalence rates of these types of adversities in the broader population, but they just tell us about kind of who were we talking to and what were their experiences. So you can see the most frequently endorsed adversities included bullying, which was reported by every single one of the autistic adults, physical abuse, emotional abuse, death of a loved one were kind of the most common things in this sample. You could also see that for a large number of autistic adults, but also a substantial number of caregivers, they reported on this standard questionnaire and other trauma. So there's something that I've experienced that's traumatic that's not on this list that you've given me. And I think it's really, really important to talk about, right? And that's where we could use the interviews to really get a better sense of what are those things, okay? One other point I'll just make on this slide is that in general, you're seeing across every type of adversity that autistic adults are actually reporting similar or more of these events than the caregivers were, which is interesting. We can't make too much of it in a study like this, but it's important to kind of keep in mind who's exposed to what kind of information, right? And caregiver report can be very important, but caregivers are often, they're taking guesses at what happened, or they might underestimate potentially what the child was actually exposed to relative to the person's own experience. So what were these others? This is where we really tried to talk to people and get a sense of the other types of trauma they were identifying, that if you really want to understand potential sources of psychological trauma for autistic individuals, maybe we need to be asking about these things. And they fell into kind of 3 broad categories. The first was a category that we named trapped, because that was a word that just kept coming up. And the types of adversities that went into this category fell into 3 kind of subcategories. One was physical restraint and also kind of pharmacological sedation. So there were a number of autistic adults, but also caregivers who were talking about the trauma they experienced actually being physically held down, restrained, or given a huge amount of psychotropic medication to sedate them, oftentimes against their will, and how traumatic that was for them. Also in this category were descriptions of kind of loss of autonomy. So not having the same ability to make decisions for yourself as other individuals of a similar age, and also kind of constant scrutiny. So just feeling like you're constantly being analyzed and controlled by others. And I think, Joette, this is a theme that would very much fall into that chronic stressor, which can often result in trauma kind of category. The final thing in this trapped domain was this loss of opportunity or self-determination. And this is actually reported by a number of adults describing this experience of graduating from high school and moving into the adult world and just feeling like there wasn't a place for them. There weren't opportunities. There wasn't going to be gainful employment. and they had a lot less self-determination than many other of their peers, and the kind of traumatic influence of that. Another big theme was social exclusion, and this came in many forms. A very common part of this, and this is traditionally asked about in many stressor questionnaires, but it was just so prominent for our autistic individuals in this study. It was bullying. But in addition to bullying, we saw kind of social isolation and alienation. Okay. So even in cases where maybe you weren't being directly bullied, not being made to be a part, right? So not feeling included, even if you are not directly being targeted, also had a traumatic effect for some individuals. Stigma and discrimination, and finally feelings of intense betrayal or experiences of intense betrayal. And this sometimes came up very chronically and regularly for individuals because allistic individuals, bosses, colleagues, parents even would say one thing and then do another, or say something, and if you interpret it in a very concrete way, that's not really what they meant. And there were a number of autistic individuals and parents talked about this in this study who they kind of recognized that it felt like an enormous betrayal, potentially traumatic, because it felt like you can't trust anything that somebody's going to say, right? They don't really mean what they're going to say, what they're saying. And a final category fell into this traumatic, we called it traumatic incongruities. And what I mean by that is spots where the way that the individual on the spectrum might be experiencing the world was kind of in conflict with the environment. So these included things like intense sensory experiences that felt traumatic, extremely loud sounds, being forced to have lotion put on your skin, haircuts and dentist appointments were brought up a lot, that these weren't just sensory stressors or upsetting in the moment that potentially could have a traumatic effect on the autistic individual. Transitions and changes. And this encompassed category as broad as, transitioning from high school into a university environment being potentially traumatic, but also moving homes or small things like the change of seasons, right? So just a change in a very specific routine being experienced as the child has a potential trauma and really shaking their whole world, and something they're having a lot of trouble moving past. And finally, in this category was something that we described as kind of social confusion, which is thinking about the potential kind of chronic stressor, potential chronic trauma of going through the world with maybe 50, 60% less information than other folks have in terms of the actual nuanced social meaning of things, right? So there being some part of the conversation that you don't have access to, so you're constantly on edge and unsure and unable to predict what's going to happen or understand why something has happened, right? And just the constant stress of that potentially having a traumatic effect. So these were the broad themes. I've given you a kind of an overview, but here are just some of the direct quotes from the people who participated in this study. So here's an example of sedation that was traumatic. One time they almost killed me in seclusion by giving me, they shot me up with enough Haldol or something that made my blood pressure sink so low that when I stood up to leave the seclusion room, I passed out. Here's a mother describing the loss of autonomy or scrutiny theme. He was schooled by himself one whole year, and it was just scrutinizing. He'd move his arm and that was a disaster. Right. So she's talking about the impact on her son of every move that he makes being controlled, analyzed, and criticized by other individuals, and also be forcefully pulled apart. And here, the mother of a 19-year-old son who is minimally verbal said, he has a real need, wanting to be successful, make his mark on society. It's such a basic need, and there doesn't seem to be any kind of support in the current system for him to do that, right? So just feeling marginalized in this really substantial way that makes you feel like there isn't really a future for you, or that you're supported in the way that society is structured. Bullying is one that's been pervasive. I almost feel like it just kept taking a greater and greater toll on my son, his self-confidence or lack thereof. It just kept adding up. So again, that's that kind of chronic potential traumatic stressor. Social isolation, a woman describes, I felt like everywhere I went, I was just treated like a space alien, yet nobody had a reason why. There was just no explanation, right? And here the mother describes that kind of distinction between bullying and the social isolation or alienation, right? They're not always the same thing. So the mom describes there was no overt bullying, but there was a lot of excluding. It had a really big impact on my son over the years. And here's the description. I tried to describe this myself, but here's in a woman, one of our autistic women who participated in the study, in her own words, when I do what I'm mandated to do, so she's talking about being in a workplace environment, I get fired or I get fined. That is probably the big thing that really sets me off. I just don't trust people, right? So she's doing to the letter what she was told to be doing, and then it actually results in her losing her job, because there are unwritten things, there are unsaid things that are actually probably being communicated. She doesn't have access to them, and it feels like she can't trust anybody because they don't mean what they're actually saying. And then this is our kind of final categories, where you just see the incongruity of maybe the way that somebody on the spectrum is processing or experiencing the environment, and the poor match of the environment to their cognitive style or their sensory experience. Here, a mom is describing her son who foams at the mouth at a haircut. We'll have to physically restrain him. Take an hour just to do a haircut. He talks about it even after it's happened. He can't get over it, right? So it's not just upsetting in the moment. You're seeing this long tail end, potentially traumatic impact of that sensory experience. A young man describes the fact that something unpredictable could happen is like the #1 fear for everyone autistic. Okay? So just thinking about the chronic trauma of that. And here's a mom describing, I don't know how I pieced it together, but the leaves were falling off the tree. She's talking about this transition of the fall. And it was disrupting to him, her son. His whole life was disrupted at the age of 4 by leaves falling off the tree. So this is, again, something when we gave her that broad trauma definition, these are the things that people told us. This is what stands out to them. Social confusion. When I'm having conversations with people, I struggle just to read their body language. It makes things frustrating. It makes me suspicious, maybe wrongly so sometimes, which causes issues, right? So just talking about that chronic stressor of social confusion again. Okay. Any questions about that? So again, these are just a really small sample of a number of really insightful, amazing quotes that really came out of these interviews that were helping us, again, kind of broaden our thinking about if we want to understand how adversity influences mental health and how we even think about what a trauma might be for somebody on the spectrum, how do we need to broaden our understanding, our conceptualization of that, and the types of things that we're asking about. That's how we were using these interviews for kind of idea generation. Okay. So what I think I want you to take from this study is that we really know autistic youth, but I think this is true for autistic adults as well, are negatively impacted by various, both traditional. So there were a lot of things on that traditional measure, right, that were endorsed by this group, including big T traumas, things that are in the DSM, which just tells you, again, we need to be asking about this for those reasons as well. Like it absolutely is true that people on the spectrum are experiencing car accidents, disasters, physical abuse, sexual abuse, right, in a way that the fact that we have such little literature on this is really unexcusable. But beyond that, we also saw some really critical big themes emerge of other types of, I would say, kind of chronic stressors that may have a traumatic impact. And those fell in these categories of kind of social exclusion and marginalization. And also that there might be some life events, haircuts, grade transitions, movings, just to name a few, and even social interaction itself that can be acutely and chronically stressful for folks on the spectrum, influencing their overall health and well-being that we were going to want to consider here. I think the open question for us is, do those broader types of events, so these themes that arose, do they actually lead to post-traumatic stress symptoms or PTSD? Are they more likely to be related to anxiety and depression and broader types of mental health? I really think that question requires further study, right? But the point is, if we don't do this kind of study first, we're not even able to ask it. So we're not even able to do that follow-up study and say, okay, is there some kind of PTSD reaction to social exclusion? Or is it a broader profile of kind of mental health challenges like complex PTSD, for example, that results from these things? But I will say that there are a couple of studies that have come out now one by Freya Rumball in 2021. She's in the UK. She found signs of PTSD symptoms. This is self-report by autistic adults in response to both traditional and non-traditional stressors in an autistic population. Haruvi Lamden, which is the group, one of the groups, I don't know if we're talking about the same one, in Israel, they also found increased rates of kind of PTSD symptoms, particularly in response to social stressors. Because when they were assessing for these PTSD symptoms, they asked about both criterion A events, so those classic DSM traumas, and they asked a number of questions about social stressors from a bullying questionnaire. And they actually found for the autistic individuals, a lot of the times they were reporting traumatic stress symptoms from the social stressors, more so than the holistic group. So we're seeing some indications of, yes, it might be really important to think about these broader stressors, not in terms of just how they influence all kinds of mental health profile of autistic individuals, but there might also be something specific about traumatic stress that are linked to these things as well that we want to explore and think about treating. I want to note that, some limitations of this kind of study design. One is it is a very small sample. These types of qualitative studies, I think, are invaluable in terms of this purpose of broadening our thinking and helping us become aware of the questions that we may not even be aware of, or the ideas or the hypotheses that we need to build into broader quantitative studies and actually to do a good job. Because there's a lot of things you won't learn the answers to if you don't know how to ask the questions, right? There were some limitations in the sample, though, in that we can't say how broad these types of stressors are for the broader population because this was such a small group and they really elected to do this kind of study with us. So this is the type of work that helps us build broader questionnaires that we can then ask from thousands of people to get a better sense of those things. But I also want to note that, we had some representation from minority groups in this qualitative study. I thought that was really important. But it might also be important to actually do entire focus studies, for example, on transgender individuals, on folks from Indigenous descent in Canada. So people who have intersecting identities that might really influence the types of adversity that they're experiencing. That was not the focus of this study. So even though we had some variability, it's important to know we may not fully understand those issues from this kind of work. I also just want to highlight that Elise, who's on the call now, did a really nice qualitative study with Anika Rai, another undergrad in our lab, also looking in these qualitative interviews about how people describe their attempts to cope with trauma. And that's article from 2022.
Connor, could we ask Kate to put the links perhaps to Elise's study and the UK study in the chat? Send it to me later and
I can send it to you later, or
Okay,
Kate might be able to hunt them up quickly, but I'm happy to give you a reference list for everything
Sure,
in the
sounds
presentation
great.
as well. Yeah. So I think I wanted to make sure that we also get to talk about some of the work that's really relevant to adults that we're also doing in the lab right now, but just to kind of wrap up this qualitative study, this description of this particular study, I think what it tells us is that we really do have growing evidence that autistic individuals experience above average rates of childhood diversity that are likely to be significantly and negatively associated with their mental health. We've seen from these studies, the relevance of this issue is really endorsed by community providers, the majority of whom, at least in the US, were screening and treating trauma-related symptoms, while at the same time saying they really need more training to do so. And our initial studies, and one illustration of this is just this qualitative work that I went through with you today. They are really suggesting a broader range of potentially traumatic stressors and also symptoms. So we have another study that's really focused on symptoms that I didn't go through today when working with autistic youth. And we need to now incorporate this broader understanding into our research, into our questionnaires and the measures that we're using in order to truly understand what their impacts are, what the impact of these stressors are, how they factor into the mental health profiles of autistic individual, and also what they mean in terms of PTSD. Okay. I'm going to skip through a bunch of stuff. I wonder if it makes sense for me to just take some questions about the research now, and then I would love to just take a few minutes at the end to talk about the particular work that we're doing with autistic adults.
Sure, that's fine with me.
Yeah. there might be one more slide that I want to show you. Okay, so I do want to show you this, which is that the study I just presented is this blue circle right here, which is it's part of a really kind of comprehensive program to develop a better measure to really be the foundation for this research that we're doing and understanding sources and reactions to adversity and potential trauma in folks on the spectrum. So we have been developing a new measure. It's called the Childhood Adversity and Social Stress Questionnaire. And the items for this measure were developed based on the themes that were pulled out of this qualitative study. They were also influenced in terms of the type of reactions that we asked about. So the presentation, what might be a traumatic stress reaction for somebody on the spectrum. We did also something called a Delphi poll, which we surveyed over 70 experts in trauma and autism, and about a third of which had expertise in both, about what do you really see as an important indicator of a potential traumatic reaction for somebody on the spectrum. And we took all of the indicators that over 75% of those experts agreed were really, truly important to assess traumatic reaction. And we used that to inform the types of questions that we ask about in terms of signs of a traumatic reaction on this questionnaire. We developed an initial form of the questionnaire or measure, and then we subjected it again to review from experts, from parents, and from teens and young adults on the spectrum about what they thought about the items, what they thought about the measure. We did something called a think aloud, and I'm hoping that actually Michelle and Charlotte, who are not here today, but they will be publishing this work in the near future. This is work we did at UBC right before the pandemic and tried to continue through the pandemic. But we had autistic adults and teens and parents do think alouds of the measure, which means they actually kind of talked aloud while they were completing the measure, told us what they thought about it, how they understood the questions, if they thought there were things that were missing, there were things that were hard to understand. And we used all that feedback to improve it. And now we do have a finalized version of this measure, one that is self-report that we are collecting data on for young adults on the spectrum and those not on the spectrum in some of our current studies at UBC right now, and also a parent version that's specifically for asking about these types of stressors in youth and getting different perspectives on things. Okay, so that is where a lot of this work has been going. And there's a whole slew of studies, and I was not able to talk about so many of them today, but I thought focusing in on that qualitative study really helps you understand the foundation of where we're coming from on this and the need to take this more tailored approach and really to make the research worthwhile. Okay.
Any questions?
Yeah, I have a question
Mm-hmm.
and a comment. I acknowledge this is a very small sample, but as somebody else has already said, it has produced some interesting and perhaps representative results. This group, Square Peg Society, tends to focus on kids who are sort of on the verge of being able to pass. So perhaps some of the things that they're particularly concerned about requires some more analysis as well. I would like to note that a lot of the things the research has focused on are things I think most parents of these kids have known already for years, to be honest. So I'm glad it's being done, but it's behind the 8 ball. I'm not sure why it is so important to differentiate the trauma that our children experience between PTSD and anxiety. Like, who cares really, as long as whatever the symptoms are managed and acknowledged. And finally, I would like some input on what's going on with transitioning. We know that 40% of the young people in particular who are transitioning between sexes are autistic. So is it possible that the sort of trauma that you're talking about, small or large t, has something to do with that sort of eventuality, that maybe people are upset about who they are because they're being bullied, for example. And that might cause them to consider their sex or gender, whatever word you're using these days.
All right, I will do my best to get through this, but I want to thank you for the comments. I'm going to start with the PTSD question, like why does it matter to differentiate? Because I do have a feeling about that. And this comes from my experience as a clinical psychologist and somebody who's doing a lot of the therapy for these presentations. The way that we would treat a child with PTSD and the way a lot of trauma-focused CBT, for example, works is different than CBT for an anxiety disorder or a CBT for depression. And the main differentiating part of it has to do with a specific feature of PTSD, which I think is the thing that differentiates PTSD most consistently from a lot of things with which it shares a lot of symptoms or challenges, characteristics. So there's a lot of overlap between PTSD, anxiety, depression, ADHD, autism, actually, right? There's a lot of behavioral overlap between all these things. And that's why you also actually, for adults who are wondering if they might be on the spectrum, a common differential diagnosis is complex PTSD. Is it complex PTSD or do I have autism or am I experiencing both, right? So there's a lot of symptom overlap in a lot of these conditions. But one thing that really differentiates PTSD, the way it's classically considered, is intrusive re-experiencing symptoms, which is having really intense nightmares and re-experiencing your trauma in a way that you actually kind of dissociate. The past in PTSD is not past. And actually, even when they look at brain imaging research, recent research, they're showing that for folks, when they're processing kind of trauma memories, it's actually held in a different part of their brain than many other memories, because it actually it's not fully a memory.
So it's not the same as ruminating.
It's not the same as ruminating. It is an intense, intrusive experience where you're actually almost brought back into the traumatic event again. And that is different than just anxiety or depression, or even depression, even though you are thinking back about a lot of negative things that have happened to you. It's not quite the same thing. And the way that the PTSD treatments are really focused is on targeting those memories to help them get processed and to help people habituate to them, and to make sure that as they're going through their life, they're not getting constantly triggered back into the trauma. So when you think about what a PTSD treatment is going to look like, it's really focused on what's often called a trauma narrative for kids, for example. And so that's where I think making some of these distinctions between PTSD and broader reactions to trauma. First of all, they're all important. So I don't want to say, like, just because you don't meet criteria for PTSD, it doesn't mean that you haven't experienced trauma and you don't deserve treatment. But we would approach the treatment a little bit differently. Like, I'm not going to help you get exposed to this memory and habituate to this memory, so it's not literally haunting you.
Right. So for a lot of people,
don't have that
it's going to be mainly sort of something lesser than PTSD.
I don't know if I would even say lesser. It's just different, and the way we treat it is different. And so, and I think the chronic traumas is a really good example of, for a chronic trauma, like we've been discussing, are we going to want to do a trauma narrative that we kind of read through over and over again and wait for the person's reaction to go down? Or is it more like a classic, something we would do in therapy, where you're really just talking about the impact of what that experience has been for the person, validating it, helping them understand why that's been happening and how to move forward, kind of thing. So I think they're both equally important, but there might be, I do think on some level that distinction is important because it has very specific treatment implications.
Right. Understood. What about the rest of my comment, particularly about autism?
Can we take a pause there and give Anne
transgender?
and I think both Anne and Pam have questions as well. So
Well, I'd like you to address the transgender issue because it's huge right now and
It
very
is.
concerning for many people.
It is. There's a lot more research coming out on it. M. Mitter-Trainer, who's a research coordinator in my lab until just last year and now is a graduate student at in New Brunswick, has done a scoping review, just reviewing all the research that's being done, looking at this issue and the quality of the work that's being done. So I am not in a position to say in any way right now, based on the research, if what the role of trauma might be in what's going on there. But I will just tell you, I'm very much like a researcher scientist and annoying sometimes because I don't like to give answers to things until I feel very confident in those answers. And the research literature is just not there yet. But what I will say is that it's a huge topic now, and you are seeing, for example, when M was doing that review, they finished it a year and a half ago. We submitted it to a journal. The journal took 5 months to get asked for revisions and hopefully accept it. And within those 5 months, the number of studies that had been published on the topic had almost doubled. So we had to take 2 months to
Well,
update everything.
I'll leave it at this. I know you have to answer other questions, but let's hope that we don't have to wait another 20 years and impacts an entire generation with people with autism.
Yeah, I think that's a whole other kind of just issue about science and dissemination as well, and what it takes for us to kind of get to the right answers with what the needs of the population are. And I'll just make one more comment about this, which is I'm very passionate about the issue of understanding trauma and stressors for people on the spectrum. I am also really nervous about moving forward too quickly and putting information out there that's not entirely accurate, because I think that can have damage too. Do you know what I mean? So it's a real push and pull. I think if you want to do right by something, it sometimes takes time to do it carefully. But at the same time, as illustrated in one of the studies I showed you today, it's clear this is a huge pressing issue and we need answers now. So that's the yin yang of it.
Good.
Thank you for your
Okay.
comments.
Anne, please.
Hi there. I just want to say that I really agree with all the work that you're doing. And it's a long time coming with those of us who have young adults. It's felt like we were kind of left out in the cold now that they're past the youth age, that they no longer have the help to support, and the need is all focused on the children. So it's really nice to see that you're doing that work. And I agree that the anxiety, stress, and the autistic individual, the youth and the young adult problem, it just worsens and magnifies as they get older. To me, from the time they've progressed, so they get the bullying and all the stuff when they're in as a teenager, and then as they become a young adult, it just becomes worse and worse, the isolation and all of the above. The difficulty is finding, I think, professionals that understand stress, anxiety, along with autism, to be able to treat these kids. They have to understand autism to be able to deal with it. And I think that's a big lack. Plus, the funding for it. The services aren't usually covered. And here these kids are making less than $25,000 a year. I just wanted to ask you if the individuals seem to fall, when I was listening to your description of betrayal, bullying, et cetera, into the PTSD, if your individuals fell more into three of those categories, and if it was repeatedly into those and other ones were fine for them, if you understand that. So say that this individual that's engaged, that's taking this study, finds themselves very much into social exclusion and betrayal, but not in another category. So I find they seem to have strengths. The adults seem to have strengths and weaknesses, just like we all do, but their spikes are higher and lower. That's my personal experience. And I wondered if you'd seen that as well.
I mean, absolutely. And I think So Elise's paper, which we'll share with everyone, really talks about, as I mentioned, kind of the ways that folks, they talked about, okay, here are the traumas I think I've experienced. They also talked about how they've responded to them and the ways that they're trying to cope with them. And in this study, so these 14 individuals on the spectrum, caregivers, there's a huge range of how people were doing. Some people really wanted to participate in the study because they had been through enormous adversity and they feel like they've been able to come out the other side, and they wanted to share that experience and they wanted to share how they coped with it for other people on the spectrum. Other people were still really in it and feeling quite distraught and just looking for the validation of finally somebody who wants to listen and wants to kind of formalize it and say, hey, we understand, like we want to make this a part of the science to get this recognized on a broader level. So I think there's absolutely, there are enormous strengths in the autistic population. And I think that deserves a study on its own. And there's some of that in Elise's paper, but it's certainly something we want to engage in more, particularly when we're thinking about treatment and how to support and prevention also, right? A lot of what creates a trauma, as we were talking about before, is the way that is experienced by the person and the type of support that they get when the experience occurs, right? So I think there's a lot of change to make there too. In terms of the profiles, I would say that the social exclusion kind of category that include the bullying, the social isolation, stigma, marginalization, betrayal, that is in the qualitative study, that was probably the most common kind of category of experiences across individuals, as opposed to kind of the trapped and the incongruities kind of categories. We have done some subsequent research in much broader samples at this point that is starting to support the validity of the measure that we've developed. So I can tell you, now you have to all remember that this is the measure I developed, okay? So I'm not like an unbiased sample, but I will tell you, I was very excited to see that when we gave this measure to a broad sample of individuals on and off the spectrum, that the items that were specifically developed from this qualitative study are the ones that are significantly more likely to be endorsed by people who are high on autistic traits or with a diagnosis of autism. Now, interestingly, it's not exclusive to that group. So there are people who do not have a diagnosis of autism that are also endorsing some of these things, particularly in the social exclusion category. But we do see, like in broader samples now, and we're just writing up these results at the moment, that indications that the work we did here with the qualitative study was time well spent, right? That these are really relevant. As I think somebody else commented before, this is not just a small subsample. We have captured some themes that are really broadly relevant for this population. We've got some data coming out to support that. We have some data entirely from caregivers talking about their children on the spectrum in the US. And there we see kind of three profiles of trauma that seems to be coming out. One is, I would say, kind of a complex trauma group, which is it was only like 10 or 15% of that US sample, but they have the PTSD criterion A traumas like abuse, et cetera, and also all of these other things. So it's a real big constellation. But then the most common group was actually a group where the majority of the traumas are these social stressors. So I think, again, we're just getting into this data and we're starting to learn more about it, but we see variability with maybe the social stressors being the most common denominator across the board.
Okay,
Great,
Pam,
thank you.
please.
Hi, and thank you for this opportunity. I want to validate what Levine said about the fact that now there's a study validating what parents have known for a very long time. And I also, not to go against any kind of science, but it always seemed to me funny that we need a study to prove something before anything can change. I remember that there was a study about, special passions from tarantulas to dinosaurs or something. And it wasn't until that study came out that people started thinking, oh, maybe the special interests are a good thing and not a bad thing, right? But we always have to wait for these studies. But I do appreciate you doing these studies. I do appreciate you capturing what families have been saying for a very long time. I also appreciate the fact that you want to make sure that it's accurate, and if we're trying to make change, it's really important. And so, because my concern is about a study that came out in 1998 that changed the world. A lot of you probably know what it is, but it was one study based on 19 children, and it changed treatment for children with autism. So what I'm wondering now is your next studies, will they be looking at the potential trauma involved with compliance-based therapies? Because that would fit all other traumas, trapped, social inclusion, and the traumatic incongruencies. So I'm just wondering if that, because I mean, I think that's something that we need to do to help change how we're working with young autistics.
Yeah, so none of our items ask about specific therapies, but they ask about exactly those concepts that you just described, which to me, as somebody who's tried to think very carefully about this issue, and it's something that's been brought up. And I want to just mention too, that a lot of the clinicians who have actually expressed interest in some of the work I'm doing and participate in some of these studies are actually behavior analysts, who have felt some discomfort in some of the work that they've done, wanting to be very helpful, but also feeling uncertain at times. And there are a number of students who work with me in my lab, including some of my graduate students who have had some of those experiences as well. To me, what is important are kind of the themes that have come out from this work about scrutiny, trapped, loss of autonomy, the way that you're interacting with a person. That is what's, I think, important more so than any particular therapeutic approach or way, et cetera. So I think that those kinds of things can be done from a variety of orientations and therapies. It's about how you work with the person, more so than any particular kind of approach, whether it's CBT, behavioral analysis, psychodynamic, et cetera. Right? There's a lot of different ways that therapy has been done. And I think it's really about the way that people are being taught to do therapy, how they approach therapy, how they identify what treatment goals are, the way that those therapists are being supervised, the way that they're constantly checking in with the person they're supposed to be helping about if it's actually helping them or not. So it's my hope that this questionnaire will really help us get to the bottom of some of those concerns that are being brought up by really illustrating that those experiences can be sometimes some things that are happening in treatment facilities. The place where they came up the most in these qualitative interviews were actually inpatient treatment facilities for a lot of the adults that I spoke to, autistic adults. So it wasn't even about behavior analysis or ABA necessarily. It was about the way they were being controlled and treated and their rights taken away in hospitalized environments. And some of the adults in the study, they were hospitalized when they were younger as well. So it's hard to know what current hospital environments are like, if they're any better or not, et cetera. But to me, it's those themes that are the things that we should really, really focus on, because I think they actually can apply to a variety of different circumstances.
Anne has another question, but because Anne's, I knew in her previous comments, she mentioned counseling and appropriate counseling. And Miriam has a question, but anyway, I wanted to ask if any of your team has a clinical counseling practice, a one-on-one practice, because we are always on the search for individuals who know something about anxiety, stress, and trauma, who understand autism, and who are taking clients. So that always comes up. So again, if they are, please let us know, or if you can or are willing to recommend any individuals who are doing that kind of work and who have that kind of background. We have been told so many times that, oh, we can't take you because you have this co-occurring diagnosis of autism and anxiety and trauma and whatever. And again, many families feel really at a loss as to where to go, and they understand, well, they understand that there are risks involved with their person going to a counselor who does not have that understanding, because they feel that, again, that concern that they won't be heard, because the way, the interpretation, the differences in their approach to and their way of seeing the world, the neurological differences will not be appreciated and understood, and therefore they will once again not be heard. So again, please, if you have those recommendations, we would appreciate them. But then let's go to Anne's question first, and then Miriam. And we are running out of time.
Say that we try and put some resources together on our lab website. Kate is a great person to interact with. I don't know if we know of anything that you don't know of, Joette. And I'm very, very much hoping that all the folks that are getting trained in my lab will be available in the community in the future. We'd love to maybe do some outpatient research work treatment in the future as well. But there's a little bit of a time problem. And I will just say too that I think what you're describing is a great illustration to me of this real conflict we have about wanting to provide an answer quickly and provide support to people quickly, you know, and also the dangers of potentially moving forward quickly, because it is both traumatizing to call around and literally be rejected from people just because you have an autism diagnosis when they know nothing about you. And they're saying, well, I can't treat you because you are on the spectrum. That doesn't really make much sense to me anymore. But the one part of it that does make me nervous is then if people say, okay, well, yeah, I can see you even if you're on the spectrum, but they know nothing about autism. Exactly. That is also something that has been brought up to me clinically as invalidating, traumatic. It makes it feel like treatment can't be effective and helpful, and the person doesn't want to seek help as more. So it's tough, right? We don't have a really specialized workforce. So we have to kind of walk this really tightrope through trying to get people to provide just a broader number of people in an informed way while knowing that they're not experts yet, right? And how do we kind of do that? So,
right. Yes, that is our experience. So Miriam, go ahead, please.
Okay, yeah, I just wanted to know, first of all, if we'll be able to get these slides afterwards.
Yes.
And also the questionnaire, your questionnaire that you've created, is that already available, like for clinicians to use or for us to look at or that kind of thing?
It's not. And like, this is where I'm kind of like a stingy scientist researcher or whatever, right? Like I'm really hesitant about letting it loose until I really understand how it's working. And if it's a good tool or not, et cetera. Because I worry about things getting out of my control, but you can absolutely look at it particularly if you participate in our studies, you'll be completing it. And we'll be releasing more information about it. And I'm thinking that it is being used by more and more clinical researchers, right? Because I'm presenting this work. So more and more people are integrating into it. I just kind of want to make sure that it meets a high standard before we make it publicly available. What could happen is that there are a lot of people using it out there in a way that's not actually appropriate and making false conclusions about it, et cetera, which would make me very nervous. And then I feel like we undermine the really important work that needs to be done.
Right. Is there an upper age limit to participate?
Sorry, yes.
Yeah, I also wanted to know if we or our autistic family member wants to participate in your studies. Is there still now, it's not too late, or you still have ways they can participate, and how can we find out about that?
Yes, I would love to talk about the studies we have going on. But I don't know if should I wait? Should I take Anne's question, then maybe go to that?
Yes, please.
Does that sound good?
Yes, okay. Please. And also, is there an upper age limit to participate in that study?
There are a few studies going on, and they will have different criteria depending on which study we're talking about.
Okay, great. All right, Anne?
Sorry, that was my question about participating in the studies.
Okay, great.
Yeah, great.
Okay, Connor, tell us about your study.
Okay, All right, so let me tell you all what's going on in terms of research studies. So, and these are just the research studies that are going on now. This doesn't mean like there might not be other good opportunities. So even if you or your child wouldn't qualify for these in particular, that doesn't mean there might not be another good opportunity for another study in the future. I am going to talk about some age limits, which I realize might be infuriating to some people, and I totally get that. And I just want to let you know that, again, kind of the line I'm trying to walk as a researcher is that a lot of times for us to understand what's going on and make conclusions about things, we need to put some limits on some variability, or it's really hard for us to make conclusions about what's actually going on in the study because there's so many different things going on in the study. So that's just the kind of the caveat. But the study where we're really looking at this questionnaire, in particular in relation to memory, which is, as I mentioned, something that we're quite interested in when we think about adversity and how it impacts people and their broader well-being, is the schema study, which we have ongoing right now. And for that, we are recruiting adults on and off the spectrum between 18 and 30. And we're asking them to complete a variety of questionnaires about their experiences, their current mental health, and also looking at different types of cognitive processing to understand how these things might be working together and what the particular ways that individuals on the spectrum, what's going on in terms of their historical experiences, but also the way that they're currently experiencing the world now that might influence kind of their mental health. And the questionnaire that I developed is a part of this study. It's in a number of the studies that we do, but particularly in this one, Kate is the coordinator for that study. It is a paid research opportunity. This one requires folks to come into our lab because we are really interested in the way that they're processing different information as well. So there's an eye tracking component that's part of it. And for that, we need people in the lab. But this is one opportunity. Another that we have going on is, for this study, for schema, it could be, you could have a diagnosis as a child, you could be adult diagnosis. We really are taking a broad range in that regard. We're just limited in terms of the age range of people on the spectrum that we're looking at here. And we're also looking at people who are not on the spectrum. And I'm thinking of anything else. I think those are the main things for this study. Oh, we do need people to be verbally fluent to participate in this study, just given the types of questionnaires that they're going to be answering. Another study that we have, oh, sorry, any questions about that one?
Oh, I didn't hear the very last sentence you just said.
Oh, I was just saying that this study, we are looking for individuals on the spectrum, so everybody who participates needs to be verbally fluent in English. Just because we are asking a lot of questions through questionnaires and in person, for which you would need verbal fluency. So it's not a study that would that folks who are require assisted communicative advice to communicate, or who are not verbally communicating, that's a struggle for them, that they wouldn't qualify for this study. So I just wanted to let that know. Everybody know that.
Connor, just as I appreciate the point about parameters in order to make the study valid and to understand what you're looking at. Just as it was only children that were considered a few years ago, there was nothing on adults. Now there's nothing on, or very little on, older adults. That 30 to 50-year-old group needs some investigation. And so, I mean, I'm not advocating to broaden it out, because I know from our experience trying to host programs of different age groups, that doesn't work either. But money for two groups would be a good thing.
I totally get it. I feel like there's not enough hours in the day, kind of thing, for all the important things that needs to be going on. What I will say is there is some really good work being done by Giacomo Vivanti, who is a collaborator and colleague of mine. He's at the A.J. Drexel Autism Institute, particularly looking at later life for individuals on the spectrum and aging. So he's a good researcher who's doing some of that work now. And Matthew Lerner is also at the A.J. Drexel Autism Institute. That's where I worked before I came to UBC. He has an entire research program that's called the Life Course Outcomes Program, a huge emphasis of which is really adulthood. So there are more and more researchers who their research is really about adults now in a way that didn't used to be the case. So I know it's slow going. I 100% agree with your frustration. 100%, but I just want to let you know the folks that I am aware of who are really owning this space now and making this space their focus in a way that didn't exist 20 years ago at all, as I mentioned. So I'm sorry I can't be everything to everyone, but there is some important work going on now, and I appreciate the feedback because it does influence our decisions about what kind of studies we're doing and what we kind of go after. So,
Okay. Are there any more questions? Kate, have we missed any comments in the chat or anything like
I
that?
have a couple other studies I just wanted to tell you about.
Okay,
Another
sure.
is Charlotte's, and you're actually the first group to hear about this study. This is hot off the presses. Charlotte is particularly interested in the experience of adult diagnosis for folks on the spectrum. So what it's like getting that diagnosis as an adult, and your experience in the diagnostic process. And she is looking for feedback from autistic adults who were recently diagnosed and also expert clinicians about kind of what the process entailed, how it could be done better. So what were things they thought could be improved, but also what was working well. I think this is a study that we're feeling is really important and we're really passionate about at this moment, just because we've been hearing so much about the need for adult diagnostic assessment and how some people's experiences with those diagnostic assessments are quite varied. So it can be a positive experience for some. It can have a lot of complications and problems for others. And there's increasing interest just from more providers about like, how do we do this? How do we do it accurately? How do we do it well? So this study is particularly trying to get some of that information from autistic adults as well as the clinical providers and kind of get them to come together and seeing what they think the recommendations for these kinds of evaluations should be. So this is an important study that's just launching kind of today, honestly, that I would invite you all to think about and potentially participate in. And I wanted to mention that in addition to the schema study, we have, why isn't it moving forward? Another study that Michelle is doing that particularly, I lost it, but is looking at anxiety in young adults on the spectrum and how it relates to social processing and social anxiety in particular. And that's something that you can actually do alongside the schema study or just independently. That one can also be done if you can't make it all the way out to UBC, that one can be done remotely. So those are the 3 studies that we have available for adults right now. And I will definitely follow up with my slides after this talk, but also specific information on those 3 studies if they're of interest to anybody in the group or also just to share broadly with others. The more people we have participating in the research, the better the research will be.
Thank you. I'll email the slides and the resources to attendees, and we'll attach a slide of that to our recording of this meeting and at the end to make it more broadly available.
Amazing.
Thank you.
All right. Any final questions?
There was a question in the chat. Anna asked, North America are countries of immigrants. Does your research eligibility take immigrants too? Since we talk about trauma, maybe it happened in childhood and it happened in another country.
Yeah, we would love people from all different backgrounds to be part of the research. That's the only way the research is going to be truly useful and help us understand these concepts in a comprehensive way. So absolutely. Usually the exclusion criteria for the studies, like for the eye tracking study, there's some things, if you're colorblind, I think we can't take you through some of the protocols. There's some things, photosensitivity, if you might be at risk for a seizure, that we can't put you on the eye tracker. So there's some few things around that. And then we were really on some of these studies focusing on this transition to adulthood and the young adulthood period. And I know, I'm sorry, Joette, that's the focus, but that is the focus on this study, just because we have found in prior research that that is a really stressful time for a lot of young adults on the spectrum, because there can be a real shift in kind of the services and supports that they have access to. And it's just a big transition moment that can be associated with a lot of mental health stressors. So in particular, that's part of why we're focusing on that age group for these studies. But that doesn't mean that's the only age group that's important, and that's all that research should do.
No, I mean, I fully acknowledge that how stressful that is for many people. In fact, that is probably the significant for our Life Map program. Most of the participants are in that zone. They're individuals who have lost the world that they know through resource rooms in schools, through that predictability of classroom life and all of that. Even if they experience bullying, even if it was not a great experience for them, it was a known entity. And also because they have many of them take longer to conceive of a life path for themselves. They really feel alone without a paddle. And also they don't have a peer group that has their back, that they feel that they can both learn from and go out into the world with. So it's a very stressful time for sure. Any other questions? Okay, I think we probably could go on for 2 more hours, but time has run out. So thank you so much for sharing this, and we will look forward to your slides and to following your research going forward. Thanks so much, all of you, and for all of you attendees for being part of this as well. Thank you so much.